Welcome, everyone, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 27, 2022. Today's CMA activity code is 486598. We've got a really interesting case today with Dr. Corbett and Dr. Oliveira. As usual, we have nothing to disclose, and to ensure patient privacy is preserved, identifying information including age, gender, ethnicity, exact dates, laboratory values, and other details have been changed to disguise the identity of the patient and to protect patient confidentiality. This conference is being recorded. It'll be up on YouTube shortly. We appreciate everybody that subscribes to our YouTube channel. And if anybody's not on the mailing list, by all means, just send us an email and we'll add you and tell your friends to join us. This is our last week of interviews. I want to welcome, we've got several people interviewing today for fellowship. I think it's our last week, which also means we'll probably be taking a couple weeks off after this. And next week is kidney week anyway. So just keep your eye open for email and we'll get going again. I think Dr. Oliveira is going to present the protocol. Mel, you want to start us?
Can you hear me? Nice. Okay. So we've got a 22-year-old white woman with a history of scalp psoriasis and HPV with cervical intraepithelial neoplasia. She was referred to our clinic for evaluation of dark urine with microscopic hematuria and subnephrotic range proteinuria. 10 months prior to her initial presentation, she was evaluated at an urgent care clinic for dysuria. Her renal function was normal. Her serum creatinine was 0.8 milligrams per deciliter. Her urinalysis at that time had blood and protein by dipstick with greater than 50 RBCs per high power field. She was treated for a yeast infection. She denied any gross hematuria, but she was also menstruating at that time. 1 month prior to her presentation to our clinic, she was empirically treated for pharyngitis with azithromycin, and her symptoms improved. And then 1 week prior to her visit, she noted dark, bloody urine that resolved after 2 to 3 days, and she was not menstruating at that time. At her initial visit, the review of systems was negative. Her serum creatinine was 0.8 milligrams per deciliter with a serum albumin of 4.4 grams per deciliter. The urinalysis had 2 plus protein and 1 plus blood by dipstick with 11 to 30 microscopic RBCs per high power field. Her urine protein creatinine ratio and urine albumin creatinine ratio were 914 milligrams per gram and 505 milligrams per gram, respectively. She was treated conservatively. We started losartan 25 milligrams, and 3 months later, her UPC and UAC were 258 milligrams per gram and 117 milligrams per gram, respectively. The hematuria persisted. Due to her history of HPV with CIN, she was referred to urogynecology. She had a cystoscopy done, and that was normal. Her past medical history was significant for allergic rhinitis, scalp psoriasis, and CIN. She had no surgical history. Her family history, her father, who was living, had been diagnosed with AL amyloidosis and multiple myeloma. She had no known allergies. Her medications included ketoconazole 2% topical shampoo, losartan 25 milligrams, and she denied any use of over-the-counter medications or supplements. Her physical exam, she had normal blood pressure. Her heart rate was 81. A normal respiratory rate. Her height was 167 centimeters. Her weight was 57 kilograms, and her overall BMI was 20.3. Nothing remarkable on her physical exam. She appeared well, no lymphadenopathy, no increased work of breathing, good air exchange. Her cardiac exam was normal, and she had no lower extremity edema. Otherwise, everything looked good. So labs at the time of her, right just before her biopsy, her CMP, her sodium was 137, potassium 4.4, her chloride was 102, bicarb was 25, her B1 was 9, and her creatinine was 0.7, with an estimated GFR greater than 90 mils per minute. Her glucose was 90. Her total protein was 7.2. Her albumin was 4. Calcium was 9.6. Her liver function tests were all normal. Her CBC, she had a white cell count of 7,000 with normal differential. Her hemoglobin was 13.6 with an MCV of 95, and her platelet count was 270,000. Her urinalysis, her specific gravity was 1.002. Her urine pH was 6.7. There was no protein, but +2 blood by dipstick with 1 microscopic RBC per high power field. Her UPC was 258 and previously was 914, and her UAC was 117 and was previously 170. Her ANA here was negative. Her complements were normal. You can see the ranges there. Her double-stranded DNA, ANCA, ASO titers, rheumatoid factor, and PLA2R antibody, HIV, hepatitis B and C were all negative. We did check an anti-DNase B antibody, which was elevated at 205, and the upper range of normal is 120. And then her serum and urine immunofixation, electrophoresis, and quantitative immunoglobulins were all pending at the time of biopsy. Her renal ultrasound, both kidneys were normal. The right was 11.5 centimeters and the left was 10.5 centimeters in length. She had no masses, cysts, stones, or hydronephrosis. And so a percutaneous renal biopsy was performed.
Thanks, Mel. Any questions?
Hey, Mel, in terms of her her hematuria, so she had it 10 months ago. She had this, and then she was treated, and then she noted it again before the clinic visit, about 1 week prior.
Right.
Correct? Okay.
Right. And so it was kind of like this mixed picture. One time when we got the urine, she I think because her father knew us, when she had this like dark urine, we got a urinalysis pre-clinic and there was the hematuria present, but then she said that she was menstruating, but then on repeat, it was there again. And then at that time she was not menstruating.
Tonsil exam?
At the time of her clinic visit, we actually did check her tonsils and they were fine, normal, no exudates, not enlarged, and we checked.
I'm sure you did. All right, we're going to start out with a poll here. Poll number 1, would you biopsy this patient? Yes or no? It's an anonymous poll. We have a lot of people on today. Let's get a lot of votes. Nice response rate. Give it a couple more.
More seconds here. Pretty good, yeah. Really good response rate.
Yeah, really.
All
Okay.
right.
The poll says that 2/3 of people would biopsy this patient, and 1/3 of the people polled would not biopsy the patient. Now we're going to have a second poll. We'll discuss all this as we go through the case. Poll number 2, what do you think this patient has? Number 1, some post-infectious GN. Number 2, thin basement membrane disease. Number 3, IgA nephropathy. Number 4, lupus nephritis. Or number 5, a normal renal biopsy.
We gotta get that background music going for these polls at some point.
I can sing, but then no one will come back next week. Steve could play guitar. I might break the internet though.
All right, pretty good. Come on, last few. All right.
That's good. So we've got about 10% with a post-infectious GN, 25% synthesis-based membrane disease, a little over half the IgA nephropathy. We've got a couple votes for lupus nephritis. So, Pravir, before I ask you before I ask you poll number 1, what you would do, why don't you discuss the case, the differential diagnosis for us?
Yep. So, oops. Can only blame myself with that click. So, you have a 22-year-old. We're basically seeing for hematuria and in non-nephrotic proteinuria. So, in terms of, the case, the history, jumped out initially. She had hematuria. She had, dysuria at that time. So you're thinking, okay, maybe this was, potentially just UTI, but then it persists, and she has this history of pharyngitis that was treated, but she still has this persistent hematuria and proteinuria. Initially, I was thinking, okay, maybe you know, it was going to be an infection related post-infectious, but that wouldn't, you know, kind of make sense initially, given that seems like it happened well before her initial episode of pharyngitis. So that kind of went down on my differential a little. And then you're thinking, okay, IgA, other things that can cause hematuria. And sure, she had an infection, didn't have gross hematuria, but not, you know, microscopic hematuria is also part of IgA, and it can resolve. So that becomes higher on the differential. Then she has some proteinuria, so that kind of elevates in my differential. The other things I consider when I see a patient with what is preserved renal function with non-nephrotic range proteinuria and a little bit of hematuria would be those, you know, post IgA, thin basement membrane disease / Alport's. And I also had autoimmune related lesion like a lupus nephritis on there as well. So what would tilt me towards some of the other differentials? Because right now I'm thinking more of IgA based on everything. Well, autoimmune, she has this scalp psoriasis, so young, I think lupus nephritis or any type of lupus related lesion has to be considered. When you go to the labs, then she has normal complements, which doesn't rule it out, but you know, her ANA was negative, everything was negative, so makes it a little less likely, but you know, it wouldn't be surprising to see something of that nature on the biopsy still, so you still have to consider that. Thin basement Alport's, I would, you know, family history, she has a family history of AL amyloidosis, but no other family history of kidney disease. With Alport's, you know, she has no other extra renal manifestations within, thinking of the spectrum of thin basement membrane. It could still be possible. You can get proteinuria. Usually you want to see a family history there. And so I guess that can still be considered, but it becomes a little lower as compared to the other ones that I mentioned. And finally, I had listed down is membranous, which unlikely, but just when you see preserved renal function, hematuria, you know, proteinuria, this is non-nephrotic. She does not fit the typical 4th, 5th decade of life that you usually see that, but not all patients fit within that. So at this point, you know, when I'm looking at her labs, preserved renal function with, you know, a little bit of proteinuria, intermittent hematuria, I think IgA becomes the most likely. Number one, my diagnosis. Number two will be that maybe she did have some other prior infection related, you know, lesion that's just become scarred, and I wouldn't expect to see something active. So maybe she'll have a prior, maybe FSGS from a prior infection, but you know, again, the timeline doesn't completely fit there. So I'll put that number 2. And then 3, I would put, you know, I would put down thin basement membrane disease, and 4 would be lupus. So that's how I would approach it.
Good.
Even within, I should say, I didn't mention the anti-DNASB level. That's elevated,
that.
but again, the HPI, and that's why I asked Mel the question. It seems that this was well before before this whole pharyngitis and infection. She had this before, and that's why I think it would be more of a IgA or even a thin basement rather than an infection or post strep related GN.
And you know, you kind of expect the C3 to be low, but this is maybe further out enough that you know, it might have normalized, and the strep titers can stay elevated for a while. ASO being normal, but anti-DNASB being elevated, I think that points more towards skin, but I'm not sure about that.
It's the anti-hyaluronidase is what was more often with, I mean, the anti-DNASB can be either one.
Okay, sorry, thanks. Anybody else have any other thoughts about this? Praveer, would you biopsy her?
Oh, I think, no. She's gotten better with the losartan. Her hematuria appears to be stable. 1 RBC. I think I don't think it would change management, so I would say no, unless there was a specific reason, health insurance or something, or if the patient really wanted to know the diagnosis, that would, you know, of course, then sway me. Okay, fine, we'll do it, but it probably won't change management, so I would say no.
2/3 of the people said they would biopsy this patient. Anybody of our co-hosts voted a yes that wants to argue why?
I think Praveer's point is a good one, is that really we should only be doing a biopsy if it's going to change our management. And it's hard to think about how our management may change here. It's always possible something rare could be there that could change our management. We've definitely seen that before. But I also think that, patient choice is important too. There are patients who, even without proteinuria, if they have isolated microscopic hematuria without hypertension, and out proteinuria, and the differential is a non-proteinuric IgA, it's your thin basement membrane or some sort of rare Alport's variant, unlikely to progress, but sometimes for peace of mind or to answer the question for the whole family, if there's this family history of hematuria, sometimes we do the biopsy. But in this case, it's hard for me to figure out how it would change management. But again, could be wrong.
Let me ask another question. She has a history of HPV, some cervical abnormalities, and she ended up getting a cystoscopy, somewhat, at least inferred in the protocol, that history has something to do with that. I don't know the answer. Is HPV at all associated with urothelial disease? I'm getting a few head shakes and stuff. I mean, we see this all the time. Patients with microscopic hematuria, they get sent to urology first, and they'll get a CAT scan, and then they'll do a cystoscopy, and they used to do an IVP, and they were all normal. And then finally, someone realizes that this might be a nephrology problem and sent to us. Which, if you really look at it all along with the proteinuria and the albuminuria, I think that they probably should come to us first. Certainly, I don't think to get a cystoscopy. I mean, it's granted, a lot of times it's already done before we see the patient, but it's not something I would refer to generally before, unless there's a very, very odd story, before I would do a renal biopsy.
Maybe in this case, I guess with her, cervical, this would be one of the few cases we say, yeah, I probably should get it done, but.
Yeah, I don't know. I just don't know. I'm kind of thinking not, because it's a different part, it's a different anatomy. I mean, it's
It doesn't explain the proteinuria, and that's why.
bladder versus cervix. So yeah.
In her case, to be honest, and a lot of this had to do with her gynecologic history and the issue of whether or not the blood we were seeing was basic, was renal versus whether it was something urologic or gynecologic. And it was because she continued to have these kind of episodes of gross blood, bloody urine or dark urine. And it was never really clear, was this strictly a renal issue or was there something else involved? And that's why she ended up seeing urogynecology, to be honest.
There's two comments in the chat. I'll mention one of them. It says, but if the findings of biopsy would help with prognosis, that may or may not be true, because once you're down to 200 milligrams of proteinuria, I'm not sure that if that's going to be as important, but I suppose it does depend what you find. And the second comment was, if it becomes lupus by biopsy, I believe it will change the management. That of course depends on what lesion we find with lupus. Although it's hard to imagine, but that's why we do biopsies, that you'd have a significant lupus lesion that would change therapy. Again, when you've got now down 300 milligrams of proteinuria and 117 milligrams of albuminuria.
But to that point, and this has come up numerous times in our conference, and more recently I saw something, I think in one of the journals, we can be surprised in lupus thinking that everything looks quite good, and all of a sudden the biopsy there's almost a discordance between what we see and what the biopsy shows. Just to kind of wrap to some degree this issue up of why was she biopsied? I mean, I don't disagree with any of the comments that have been made. I mean, we obviously biopsied her. A big part of this was the fact that her father, who actually developed myeloma at a relatively young age with amyloidosis and ended up getting a bone marrow transplant, the whole family was very nervous about the fact she had any abnormalities in her kidneys. So in some respect, we discussed all the potentials. We discussed the potential of just not doing a biopsy and continuing to follow her as she was. But I think in all honesty, they were really nervous about what was going on, and they just wanted some peace of mind to have an answer wanted something, a diagnosis, I guess, if you will, to kind of hang their hat on as to what was going on.
Mm-hmm.
I will comment that recurring bouts of gross hematuria would make thin basement membrane nephropathy a very unlikely diagnosis. It almost never presents with episodes of gross hematuria. I was not in the group that recommended a biopsy in this case, but when Steve says the family was pressing pretty hard to have a biopsy and to try to get a diagnosis, even though it won't make much difference in her management, I think that probably has to be taken into account. I was a little surprised that C3 glomerulonephritis was not included in the differential diagnosis. Let me just put forth a hypothetical in the STEM. If it said a 22-year-old woman recently immigrated from Cyprus, would that change your differential diagnosis in any way? Well, I think it would, because in Cyprus, of course, there is a high prevalence of genetic complement factor H5 as a cause of hematuria and proteinuria, which is often mild. So I would have definitely included in the differential diagnosis, probably above lupus nephritis, C3 glomerulonephritis.
Despite a C3 that high, I mean, I know they aren't always.
I don't think the C3 can be used at all because many patients are perfectly normal. I don't use C3 as I mean, if it's low, yes, but then in this case, it raises the issue of lupus and post-streptococcal GN to an equal extent. But the fact that it's normal makes no difference.
Great. All right, well, I think it's time for the wheel.
I'm sure it won't be this, while we're waiting anyway, but if someone has allergic rhinitis like she did, we always think about vasculitis as well. Her rank was negative. That's not going to be the answer, but it's something to think about.
Roger, the wheel videos, I can't see. Oh,
Yeah, 1 second.
the wheel's not ready. We will have to wait.
It's 2 weeks in a row. There's something new about Zoom cutting out. How's that?
Yep.
All right. Sorry about that delay. I'll blame that on Purdue this time. The technological scapegoat. Kelly.
All right. Kelly, let's see.
Kelly is second-year fellow, chief fellow. I think well prepared to walk us through the pathology.
Kelly, you'll have to, I can't switch who you logged in with. Kelly, Neelam. Okay, give me 1 second. All right. Go ahead. Go ahead. You should be able to unmute yourself now. Perfect. And I'll give you control. Give me a second there. All right. Click on this. Yep. Click on the screen.
Okay, give me a second.
There we go.
Okay, we have a lag here, so bear with me. Is it advanced for you?
Not yet. Keep on going. There we go.
Okay.
There we are.
Okay, so here we have one core. This is the trichrome stain, and here we're looking for any scars or any scarring. This core actually looks really good to me. All the tubules appear back to back. This is a really good sample. Lots of glomeruli throughout. I wouldn't say that there's really any scarring at all.
Yes, yeah, right, Kelly. There's 30 glomeruli, none globally sclerosed, and no cortical scarring. Good sample.
Okay, so here's a little bit closer view of the core. We're viewing an H&E stain here. So I'm gonna look at the glomeruli first. Nothing is jumping out to me in terms of like scars or crescents from what I can see here. The tubules all look back to back. I don't see any like interstitial infiltrate at all. Is this an artery here or?
Yeah, interlobular artery.
Okay.
Yep.
Yeah,
That looks normal, no sclerosis. Yeah. And there is a couple red cells. Okay, yeah, but there were a couple red cells in a cast over like by 3 o'clock. So
oh, I see it right here.
yeah, right there. Yeah,
Yeah.
yeah. So there really is a glomerular hematuria.
Okay, so here's a more higher power of 1 glomeruli. We're still on an H&E stain here. So here's the hilum of the glomerulus. The capillaries all appear open. I do not see any necrotic lesions at all here. Obviously no crescents. Bowman's capsule is all intact. Maybe a little bit of mesangial expansion kind of at the top of the glomerulus, maybe at like 12 o'clock. But otherwise pretty normal to me. The tubules around the glomerulus, I didn't mean to do that. The tubules around the glomerulus, again, appear normal to me. Yeah, I think this is pretty normal.
Yeah. Yeah, and there's a question. Those are unlicensed red cells in the capillaries.
Yeah. Okay, next slide. Okay, so is this no, this is not the same glomerulus. Okay, so we're looking at another glomerulus with the PAS stain. This glomerulus, again, overall looks pretty normal to me. The capillaries are all open, maybe a little bit of mesangial, where's my mouse? Maybe a little bit of mesangial hypercellularity kind of in this area here, but Bowman's capsule is intact. I don't see any like proliferation of the parietal cells at all. Looking at the tubules, the brush borders actually all appear intact. Let's see. I don't really see any sloughing off of any cells to indicate like ATN. Again, pretty normal to me.
Yeah, yeah. And
Nothing.
incidentally, there's a couple protein droplets in some of those tubules around 3 o'clock. If you see the little,
These little,
a little bit of protein reabsorption droplets.
Are you seeing anything in terms of what our differential was at yet?
I mean, nothing yet. Everything's appeared pretty normal. So I guess thin basement membrane disease could still be in the differential. But all the glomeruli so far have appeared normal.
Well, you said there's mesangial hypercellularity and
Okay, yeah, that's true.
so that kind of
That's
brings
true.
a few things in. I mean, lupus,
Yeah.
IgA.
Yeah, that's true.
And I think normal has been ruled out now that we know that they are the RBC cast. I mean, that's nice to see. Let's say that the immunofluorescence is negative and we don't get an EM or something with the sample, then we have to think that it would be a thin basement membrane disease. So the noticing that RBC cast by you and David was a really good pickup.
Okay, so now we're going back to the H&E stain. We're looking at another glomerulus here. This one does not appear normal. So this appears to be like an area of necrosis in this area. I don't know.
Yeah, good.
I don't really see karyorectic like debris necessarily.
Keep going up. There's a couple black dots. Yep.
Like here?
That's the fibrinoid necrosis.
Yeah.
And then if you move the arrow up a little bit more, there's some smaller black. Yeah, right there.
Oh, okay.
Yeah, that's karyorectic debris.
Okay.
Yeah. So a segmental necrotizing lesion.
Yeah.
Right across it, David, on the left, is that just kind of at the, I guess, 11 o'clock? Is that more just mesangial hypercellularity? I guess
Yeah, I think
the loops,
mesan-
never mind, I see
a
the
little
loop.
bit of mesangial expansion and hypercellularity in that area.
Okay. So this is again, H&E stain. We're looking at one glomerulus. Again, not a normal glomerulus here. So kind of in this area, 11 o'clock, you can kind of see the parietal epithelium proliferating, maybe like an early crescent forming with, I assume this is also kind of like fibrinoid necrosis in this area as well.
Yeah, yep.
Yeah,
Yeah, two out of the 30 glomeruli.
2 out of 30. Okay.
yeah.
Yeah.
And in fact, on the next stain, we'll see, the next slide, we'll see this glomerulus on the PAS stain. If you want to
Okay.
advance,
So,
yeah, you could
okay.
see the crescent
Yeah.
forming a little bit.
Yeah.
Early cellular crescent, like you said.
Okay. So this is the silver stain, looking at what looks to be like a normal glomerulus. So with the silver stain, we're looking for any evidence of ruptures in the basement membrane, spikes and holes. And looking at the basement membrane here, I don't see any breaks for sure. I mean, membranous wasn't really on our differential either, but I don't see any spikes or holes here. So overall, pretty normal glomerulus. This is the hilum here.
Yep.
Before the IF, I guess IF is where it's going to be, right?
IF is where it's going to be, yeah.
Could it still be? Oh, there it is.
IgA is positive. And then it would be in the mesangium.
Yep.
Okay, we're moving on to EM. So to get ourselves oriented, this would kind of be this would be the mesangium. In here we would have like the lumen of the capillary, the basement membrane, and then the urinary space. So looking at the basement membrane itself, it looks pretty normal to me. I don't see any electron dense deposits at all. The podocytes appear normal to me, no effacement. The thickness of the basement membrane, I'm sure we'll get a measurement, but it doesn't look particularly thin to me. The mesangium itself, so obviously we're looking for deposits here. So I think all of like, is this a big deposit here? And
Yes,
then here, here. So lots of deposit, and then even down here, electron dense deposits.
yes.
Okay. All right. So again, we get a better, even better view of the mesangial area. Right here's a big electron dense deposit. And then even down here, this is the lumen of the capillary, basement membrane, and then the podocytes, and then the urinary space. Basement membrane, again, I don't see any electron deposits here. And then the podocytes are not, they appear pretty healthy. No, no effacement.
Yeah, just focal, like around 11
Focal,
o'clock.
maybe
You
like
could see-
here?
Yeah, right there. There's a little
Okay.
flattening. Yeah, just focal though.
Okay, just focal. Okay. Okay.
David, was there a measurement? Did I miss it?
They were within normal limits.
Okay.
Yeah, so yep, so our diagnosis here would be necrotizing IgA.
Yeah, good read. Really nice read, Kelly. So we're getting a lot of stuff in the chat box about wow, and good thing we biopsied, and big surprises, etc. But there's a couple other ones, like Dr. Friedman says, how did C1 lesion change management? Dr. Classic basically saying the same thing. We'll get to that as we go through this. Pravir, you're obviously not surprised. Was there anything that surprises you about it?
Well, I surprised about even though we'll talk about it in terms of the C1, the crescents. We anticipated IgA, which was on the top, but I mean, as Kelly was going through it, I was like, oh, maybe it's lupus with the mesangial, and that's something we say it's never lupus, but it can be lupus. It's usually the other way around. It usually is lupus. I was surprised by the crescentic lesions, although again, it was 2 out of 43 glomeruli. So not shocked that there was a lot of activity based on, her overall picture, her urine studies, but I guess that's where we'll talk about if that changes anything. Didn't expect a lot of scarring, which was good. I mean, that was a really good sample. There wasn't any tubular interstitial, really fibrosis, David. I think I didn't see anything on those cores. So I don't know if you read out like less than 10% or it looked like
There was no interstitial fibrosis.
Yeah,
David,
there was no fibrosis.
Was there any sclerotic glomeruli, David?
No.
No, I
No.
mean, that all kind of is good news. And so that goes along with, I guess, good for her in the long run. But yeah, I was just surprised that there was some crescents, but I think that's kind of what I think we're going to talk about today is, what that means and what do you do with it?
So this is like a small fire in a big forest, and the question is, does it stay a small fire, or does the fire spread to the whole forest? And that's going to be, I think, the point of the discussion.
I wonder if an infection, if she had IgA, it sounds like somebody just comes apart, and maybe this infection set off a little bit of, I don't know, maybe that's part of it, why she hasn't made crescents. Maybe there were more, or maybe this is from her recent infection that kind of set it off. I don't know.
Yeah, it's hard to tell. 4.6%, crescentic IgA by the old definition was greater than 50% of the glomeruli involved. It was the KDIGO has since changed that and no longer discusses it as a percent, but more of a clinical presentation, whether their recommendations about treatment. Unless anybody else has any real comments, someone hand it over to Steve, and he can tell us what his thoughts were. I knew he thought a lot about this because in one respect, there's crescents, and we've always made a pretty strong argument that a crescent is a crescent, and it didn't matter how many. But there's always been the literature telling us that may not apply to IgA nephropathy, and we've all, I think, argued both sides of it. I know Dr. Gashey's had cases much worse with this than this, and he's treated pretty mildly and done very well. Then we've seen other people, with crescentic IgA do very poorly. And I think, Steve, you looked at our population, I think last year, and I think you've put a paper together on this. So, Steve, why don't you tell us your wisdom about crescentic IgA nephropathy?
Fair enough. I didn't know if you were going to have another poll on treatment or not.
Oh yeah, I'm sorry, we do.
Here's the follow-up. Here's a follow-up.
Yeah, this is
thanks.
just some of the labs that we're missing. No surprise. For a person her age, it would be, even though her father had a paraproteinemia and myeloma and amyloid, for somebody under the age of 40 to have that is extremely unusual, especially 20. So not surprisingly, the urine and serum immunofixation, free light chains were normal. What was interesting was that her total IgA was elevated, which you see occasionally in IgA nephropathy, but not often. Maybe it's half the time. And her IgA1 was elevated. And again, this is non-specific. We don't know if this was, this is the galactose deficient IgA, but I thought it was interesting that it was elevated. I actually was surprised that they even subtyped it here. That was the first time I've ever seen that. CRP and SED rates we did just because of the crescents, and it was actually normal. I mean, historically before ANCA, I remember when I was a medical student and resident, that's what the rheumatologists and allergy immunology people who followed the granulomatous polyangiitis patients would follow SED rates and CRPs. And the ANCA, not surprisingly, which is an IgG ANCA, was negative as well. Anyway, so that's just to kind of complete the circle as to what was pending. And then
so we have a poll. Thanks for reminding me, Pravir. We have poll number 3. So how would you treat this patient? Forget about any cost considerations related to treatment. Forget about compliance, just how would you treat this patient? Number 1 is RAS inhibition with or without fish oil, with or without hydroxychloroquine. 2 would be oral systemic steroids. 3 would be budesonide, 4 would be cyclophosphamide, and 5 would be rituximab. Give a
Interesting.
little time for some votes.
A good response. A few more seconds here. All right.
So Dr. Gash, you just asked me, what about putting SGLT2 inhibitor in there? I probably should have put that in there as well in number 1, but basically number 1 being a conservative non-immunologic therapy. So thanks for reminding me of that, Casey. Of course, I thought of fish oil and Plaquenil and that SGLT2 inhibition, which is, all the rave lately. So the results are the highest is conservative therapy, then oral systemic steroids, then budesonide. Actually, it's funny, it goes all the way down with a couple of people with cyclophosphamide and a couple of people with rituximab. So interesting mixture. Steve, tell us your thoughts on this and what you decided to do and what you based all those decisions on.
Well, I wrestled with this. Now I know.
You're
I
controlling the screen.
Okay. I wrestle with this. I know talking about this in front of Dr. Glassick's like bringing, sand to the beach, and he's been involved, and I remember over the years at the board review course, not the board review course, but the pre-courses in ASN, Dick would always do these great reviews on IgA nephropathy. So, and he's been on the KDIGO guideline committee for the last 2 at least, and probably more in the 2012 and 2021. But, for me, it was just another opportunity to kind of go back and look and see what's out there. And, as you all know, the initial Oxford classification, Crescents was left off the classification. But after this study, which I found very interesting, and I think it's a good read, that Mark Haas did with his other colleagues, many of whom were in the Oxford classification group, they looked at basically 4 studies, Oxford, Valiga, a Japanese and Chinese study, which was over 3,000 patients, looking at the value of Crescents. Now, the majority of these patients were white or Asian. Very few were African-American, and actually most of these were European descent as opposed to, North American, if you will. And there were essentially no Black patients involved. We did look at it in our population, and we found Crescents in about a third of our patients, and in the Black patients that we biopsied, a third of them had Crescents. Now, granted, it's a select group because we're biopsying them for a certain usually a specific reason. I know Roger always gets excited about the issue of, whether or not there's a value of defining a crescent, but they, when you're doing a study, you have to do that. And so they defined a crescent as extracapillary proliferation of more than 2 cell layers of any size. Now, some studies will say it's got to be more than 20 or 25% of the circumference of the Bowman's capsule. Basically, in this, they looked at least 2 cell layers deep. It could be of any circumference. A cellular crescent was defined by more than 50% of the crescent having essentially cells or with nuclei. A fibrocellular crescent had less than 50% cells with less than 90% fibrous matrix, and a fibrous crescent was greater than 90% matrix. And these studies looked at cellular and fibrocellular crescents, at least this study, and many of them do. Interestingly, in this particular study, crescents were present in 36% of the patients. And as you can see right here, as Roger alluded to in the 2012 classification, crescentic IgA was basically defined by greater than 50% of glomerular with crescents, which is very few. The majority of these patients have less than 25% crescents. They broke it out from 1/12 to greater than 1/4, which is 25%, 1/12 is around 8%. And they were looking at what percent got treated with immunosuppression. And interestingly enough, not surprisingly, the larger proportion of crescents in the glomeruli, the greater the number of patients that would get immunosuppressive therapy. But even patients that had over 8% got, 50% of them got immunosuppressive therapy. When they looked at who got treatment versus those that didn't. The patients that got treatment had a lower GFR, higher proteinuria, a greater proportion with of glomeruli with endocapillary proliferation, and a greater proportion with crescents. But on average, though, it's 10% versus 7%. So we're not talking greater than 50%, which means the threshold out there for treating crescentic IgA is fairly low. At least that's what it appears. The other thing they showed was that with an increasing proportion of glomeruli having crescents, renal function decline per year increased. So no surprise, the larger proportion of glomeruli with crescents, the greater the loss of renal function over time. And what they ultimately found was overall, all patients, if you had a crescent compared to no crescent, your hazard ratio of progressing to an endpoint, which I believe was doubling creatinine or end-stage kidney disease, was about 1.37. If you didn't get immunosuppression, it was 1.5. If you did, the difference was no longer significant. So those that got immunosuppressive therapy had a good prognosis relative to patients that had no crescents. When they broke it down in patients that had less than 25% crescents, the hazard ratio was around 1.5. If they got immunosuppression, there was no difference. If they didn't, they had a significantly worse prognosis, which basically in this group meant that getting immunosuppression essentially eliminated the difference in outcome between those with crescents less than 25% and those without. But when they looked at the patients that had greater than 25% crescents, the prognosis, although better if they got immunosuppression, was still significantly worse than if they had no crescents. So the presence of crescents was prognostically important, but in patients who got treated, if they had less than 25% crescents, the difference went away. What I thought was important about this paper was this comment, which I think says everything. Our findings should not be taken as specific treatment recommendation. Whether and to what extent the benefits of immunosuppressive therapy on renal outcomes in IgA nephropathy are modified by the presence and/or fraction of glomeruli with crescents needs to be addressed in a separate study. So I think that was really, an important and a wise comment to make. Here comes another study now, which I thought was interesting. And I looked at all of this again when we were doing our paper, and it was kind of fun, kind of rediscovering, because there are a lot of papers out there looking at crescents and IgA nephropathy. I found this one in particular, the Haas paper, I thought was everyone should read. This one I thought was particularly interesting because what they did was they looked at less than 5% crescents, 5 to 9, 10 to 24, and greater than 25%. And this just shows the overall outcome in the Kaplan-Meier curves with the increasing percent of crescents at basically 5 years. If you had less than 5%, the overall outcome which was doubling of creatinine or end-stage kidney disease, was quite good. And the outcome was worse with an increasing proportion of glomeruli having crescents. But what they found was that patients with less than 5% crescents, not unlike our patient, and those without crescents had a comparable prognosis. It was really the patients with greater than 5% crescents in particular that they felt need to have closer attention paid to. It didn't really, comment on whether they should be treated or not, but I think appropriately, they point out that these people you can't just assume they have a good prognosis and just forget about them. You need to follow them closely. As a result of all these studies, and in particular the Haas study, the Oxford classification group with Hernan Tremarchi, who I've had the pleasure of meeting, and actually he invited me years ago to Argentina they have the ASN, the Argentinian Society of Nephrology down there. He was the lead author in this, but the Oxford group in essence got back together again, and as a result added the crescents to the MEST score in 2017, so that now there's MEST-C. How this is going to impact therapy, I think is still up in the air. I think the KDIGO guidelines, which as Roger's already alluded to, and again, Dick was very instrumental in putting together, sums it all up. it's no longer defined by crescents, it's defined by the clinical outcome, the rapidly progressive GN, not crescentic GN. So defined here by greater than 50% decrease in EGFR in less than 3 months. They feel that a kidney biopsy is essential in these cases. And again, in the RPGN cases is what they're alluding to. Crescents in the absence of a change in EGFR does not constitute RPGN. Close follow-up required if the EGFR declines, and consider a second biopsy. And then in patients with RPGN, they should be offered treatment. Again, RPGN being defined here clinically by this course. So I think, very wisely, just the presence of a crescent in IgA at least, the guidelines are suggesting, you don't have to necessarily go out there and start putting the fire out with Cytoxan and steroids, but you do need to follow them closely. In this lady's case, we went ahead and, there is this tool that can be used. Now, it doesn't include crescents, but we went ahead and there's 2 of them now. One is at the time of biopsy, and I think the other one can be done a year or so after the biopsy. But since we did this, so we calculated this at the time of biopsy, and it takes into account EGFR, blood pressure, protein, age, race, RAS treatment, MES score, immunosuppression, and follow-up at 80 months. I mean, her risk of a 50% decline was 3%. So in her case, we continued losartan alone. I actually suggested fish oil, which I still think has some benefit and has very minimal, if any, downside. Didn't put her on hydroxychloroquine, didn't give her SGLT2 inhibitors, suggested she might try a diet low in gluten. And after 9 months, after the ARB, 4 months after the biopsy, her creatinine is 0.6, negative for protein by dipstick, 2+ blood, but 0 red cells, which, since we have a send-out lab, just to me implies these were all lysed. And her urine albumin and urine protein creatinine ratios remain fairly stable at around 300 and 130 milligram per gram, respectively. And she's had no gross hematuria since. So I will leave it there to hear other comments. And
There was a time
opinions.
for years, we would always argue that if somebody had vasculitis and they had 1 crescent out of 20 or 1 necrotizing lesion out of 20, it wouldn't influence our therapy. Why should we take a different approach with IgA? The necrotizing lesion and necrosis is necrosis, a crescent is a crescent. And I've made that argument forever. I know you have. I think I've been more aggressive treating crescentic IgA nephropathy than was suggested by the literature. But I think, it's not really supported what we've said. And I think you've made the the point here is that there is something different about IgA, that the presence of a crescent or crescents alone does not have the same prognostic value as it would with a vasculitis, and it's a different disease. So I find that interesting, and I think that it's changed my mind a little bit and kind of moved me more into Dr. Gashti's boat, which is what he's been kind of telling us all along. And I've been kind of reluctant to move there.
I think you're right. I mean, it's one thing if you have patients with ANCA-positive vasculitis who have run crescent. I think most of us would feel a little uncomfortable about just continuing to watch that if they had an MPO or PR3 ANCA and they had a crescentic GN. I don't know if it's just because we know those patients can go ahead and like a wildfire can get worse, and we may be catching them earlier on if they only have a few, or if it's because, we have something we can measure and follow as we treat them. I don't have an answer to that, but I know, you and I've talked about this before, even in lupus, 1 crescent makes us uncomfortable and at least gives us a sense that we should be treating them, very aggressively, if you will. Dr. Glassick, I know you have to have comments on it.
No,
Because
Steve,
you've read this literature probably as much as not more than anybody here.
Steve, you did a wonderful job, and I agree 100% with your conclusions and how you manage this patient. I want to point out that the KDIGO guidelines strongly state that one should not use the MES C score for making decisions about how to treat patients. They say that 2 or 3 times in the recommendations. And that includes crescents, except in patients who have a rapidly progressive glomerulonephritic syndrome, which you've covered very nicely. The question now, and I don't think we have a good answer, is there a threshold of crescents above which some kind of treatment offers better outcomes? We didn't see that in the STOP IgAN trial. The testing trial still hasn't been analyzed or published yet about the influence of crescents, and retrospective data such as Haas and the Chinese workers have shown maybe a 5% threshold should be used to make decisions about treatment. Well, this means that we're going to have to be very careful about sampling error, because 5% of 10 glomeruli versus 5% of 40 glomeruli is a very different proposition in terms of the certainty of the value of percent glomerular involvement. This is a very knotty problem, and I don't think we have a good answer yet. And I tend to be conservative like you, and don't start all patients with 1 or 2 crescents out of 20 or 30 glomeruli on steroids or cyclophosphamide or budesonide. I think observation with conservative treatment is justified, at least for that group with very few crescents.
It is interesting when we
Yeah.
look back at our own data. When Dr. Ramani and I last year for a poster at the ASN looked at ours, I mean, 2 things came out. It was interesting. One is that, again, and this is obviously a selection bias. These people are getting biopsied because of an indication that, I mean, we don't biopsy most patients that even like this who have, microscopic hematuria and low level of proteinuria. I mean, in her case, we did it because of the reasons I discussed, but so the group that we ultimately do biopsy usually has a little more going on. And it was interesting, at least for us, that our African-American patients, who ended up making up almost 20% of the patients with IgA that were biopsied, a third of them had necrotizing lesions, which I found interesting, which was similar to what we found in Asians and in our white patients.
Right.
The other thing that was interesting was that, because these are all our patients, so I was able to find, for the most part, treatment data. 80% of those patients that had crescents got treated. Now, 20% of the patients without crescents got treated.
Yeah.
So clearly we have a low threshold here as well. And I'm sure I'm one of them in the past of treating with immunosuppressive agents. And this could be just steroids alone or steroids plus something in a patient when we see a crescent. And that's part of the reason I was really interested in this particular case, especially when you have this low level, is to, what would people do and what is the right answer, which I don't think any of us have. And I think it's interesting you bring up 5%, because that seems to be in the one paper, that's the threshold they suggest, if nothing else, paying closer attention to, even though I have to admit, in this young lady, I've been paying close attention to even less than 5%. But I think the threshold in general has been pretty low to treat these patients with immunosuppressive agents, maybe in part because there hasn't been a lot of good data out there to help guide us.
Yeah, and 5% is one thing with 200 milligrams of proteinuria. 5% could be very different if she had a gram of proteinuria.
Yeah, it wasn't the proteinuria that bothers me as much as anything. It's the hematuria that was bothering me. And, and they're...
Yeah, but that's, patients had, that's kind of their baseline. Now, I know it's worse if they have chronic microscopic hematuria. She kind of had a little bit of both. She had episodes of gross hematuria and chronic microscopic hematuria, but I don't know I know that does change the prognosis somewhat, but that's just, a common finding. We've seen people that have it for 40 years and nothing really happens to. To me, the biggest prognostic factor here is the proteinuria, and it went down. And I wonder if there was 10% crescents with that response to mild therapy if I would treat the patient.
Yeah, I haven't been. If she had 10%, I think I'd be a little more inclined to, for lack of a better reason other than this is a little more involved. I have to, the only point I was trying to make about the hematuria is, many papers in IgA even don't look at hematuria as an endpoint. They look at proteinuria. And there was a paper out not too long ago in JASN that really suggested that we should be looking at hematuria as well, and that those patients that, the hematuria resolves, have a real, I guess, a true remission and have an even better prognosis. With this young lady, what's happened, we didn't give all the urinalyses. Sometimes these urinalyses have 40, 50 red cells in there. And that's part of the reason that, the cystoscopy, in all fairness, was done after the biopsy, but it was done because she continued to have these large amounts of microscopic hematuria. And I was never sure if that was a reflection of her kidney or if it was something else. And that's why I really wanted to see if there was something confounding it that was urologic in nature or gynecologic. That's what made me nervous, because even if her proteinuria is 250 milligrams, if she's got more active necrotizing lesions, that could be responsible for this hematuria getting worse. Now, granted, you would expect her creatinine to get worse too. So I'm kind of following all of it.
Yeah, and that's reasonable. You just have to wonder, let's say that she had 20%. Our go-to has always been cyclophosphamide, but we don't even know what the right treatment is for crescentic IgA nephropathy. I mean, if it's RPGN, I think we would probably all be aggressive. But what if you found 15% crescents and a gram of proteinuria, but a stable creatinine? And I don't know the answer to that. But
No, I don't
there's
even.
so many different permutations that we don't have the answer
It's a
to.
20-year-old woman, who's got a long life ahead of her, and there's all kinds of things to take into account, like the discussion last night about fertility, et cetera. All those things come into play. I mean, the KDIGO guidelines suggest cyclophosphamide and glucocorticoids. I think probably because there's more experience with that. I don't know if MMF would be as good in this. I mean, MMF in the eurovasculitis study was, I think, co-equal to cyclophosphamide. Rituxan could be another thing. I mean, there are a lot of options, and I think this
There are a
is
lot of options. I don't
I
think
think there's
MMF
a situation where you discuss them all with the family and you decide which one they think is best for them.
Yeah, I don't think the data with MMF is so good. There's emerging data with rituximab, and I think that might be probably a really good option with very little data, but I think it'd be a lot safer. And you make a point, a young woman in her early 20s. Dick, what kind of crescents would it take for you, or is it really not the crescents like you said? It's the clinical presentation, just like we argued last week about treating your
that's a good question. I think if you see circumferential cellular crescents which rupture Bowman's capsule and are associated with fragmentation of the underlying GBM, those are very bad prognostic signs for crescents. A few cellular elements in Bowman's space with intact basement membrane and intact Bowman's capsule, those can easily resolve without any sequelae. And we know that from post-streptococcal GN biopsies, serial biopsies, in which crescents can completely resolve if the basal membrane is remains fairly intact, and particularly when Bowman's capsule remains intact. In an IgA nephropathy, the crescents very seldom cause disruption of Bowman's capsule, unlike ANCA-vasculitis or anti-GBM disease, where that is much more common.
That's a really good point.
I think the crescents in this, there is underlying necrosis, fibrinoid necrosis. I wouldn't be surprised if you saw a few disrupted basal membranes in EM, but the crescents are very segmental, they're very cellular. I think they can resolve it without permanent sequelae in a patient like.
Heather Reich years ago, and I know I bring this up a lot amongst my colleagues. I was at the ASN. I forget if it was a pre-course or if it was just during the ASN with a segment on IgA. But Heather, I remember, brought up exactly your point, Dick, and she threw up pictures not unlike the picture on this young lady, where it was a couple cell layers, took up maybe 10 or 15%, and she showed that, and she said, this is not the same kind of crescentic glomerulonephritis that you think about in patients that have, vasculitis, if you will. And she made a strong point that people that have these little mini crescents, whatever you want to call them, with IgA, just as Dick alluded to, those patients can get better on their own. You don't need to put it out with, an atomic bomb. You can just continue to follow them. And for some reason that resonated, and she never wrote it up, but I just always remember her making that exact point, is that all crescents aren't the same. And these small crescents like this in IgA that get reported out as crescentic IgA, you have to be careful about how aggressive you're going to be, especially when they're that small and involve very few glomeruli.
And I've been guilty of in thinking, I'm too much of a lumper sometime. A crescent is a crescent. So I think this is a kind of an important discussion to realize that. And Dr. Glassick's point about post-strep, where you can have a lot of crescents, does not necessarily end up with a sclerosis glomerulus, is a really good example of exactly that. And that, if it's just cellular proliferation without destruction of the glomerular tuft or Bowman's capsule, that's could, just like bad DPGN in lupus can, you can end up with a normal looking glomerulus after that, so I think that's a really good point. I want to have, there's one mention in the chat by Dr. Suki, says, does the presence of elevated IgA1 not warrant more aggressive therapy, especially budesonide? I don't have an answer to that. Does anybody have a thought on that?
Like I said, I don't know, what type of IgA1 that is. I mean, IgA1 is, I don't know if that represents, galactose deficient IgA1, or if that's just IgA1 normally that's elevated for some other reason. And I don't know, it was interesting to see. I don't know that it directs therapy per se. I know, again, Dr. Glassick has reviewed this literature, and the whole issue of anti-glycan antibodies might be helpful, but we can't measure those.
Waddy, there have been studies of the prognostic value of increased serum galactose deficient IgA1 in patients with IgA nephropathy. You can, depending on who you read, some people say it has prognostic value, others say it doesn't. So I think it's a bit up in the air. And of course, there are patients who are relatives of individuals with IgA nephropathy that have elevated serum galactose deficient IgA who have no disease at all. That's been known for a number of years now that, primary family members of IgA nephropathy will have elevated IgA, galactose deficient IgA. I think we need more data before we could use these serum biomarkers for making prognostic and therapeutic judgments.
So I'm going to wrap this up and get back to my analogy of the fire, the campfire in the forest that remains a campfire or turns into a forest fire, and whether or not we need to put it out. And I think Dr. Glassick, he's not only not worried about putting the fire out, I think he's going to bring marshmallows to that fire. So that's his benign assessment. So I'm going to leave it with that. And thank you everybody for coming. We'll be off a couple of weeks. Hope to see you all in Orlando. Come up and talk to us. We'd love to meet you in person. And until we come back, everybody stay safe.